Yeah, acute graft versus host disease is still the major cause of mortality and morbidity after transplantation, and the standard of treatment is currently high-dose steroids. Usually we recommend to start with 2 milligram per kilogram, except in patients with minor manifestations of acute GvHD. There you can also start with 1 milligram per kilogram. Unfortunately, there is no superior treatment since many years. It has been tried to combine other drugs with corticosteroids, but in randomized trials, this did not improve the outcome. So the standard is corticosteroids for first-line treatment. We then have to define when a patient becomes steroid resistant. Usually we should use the European Leukemia Net or EBMT definitions, which means 3 progression of graft versus host disease after 3 or 5 days of treatment, or no improvement of severe graft versus host disease after 7 days of treatment with corticosteroids, or of milder graft versus host disease after at latest 14 days of treatment. Then usually it's recommended to start a second line of treatment. And again, we are in a situation that there is no approved drug for second line of treatment. There are a lot of options, but always if you have a lot of options, it means there is no real superior approach. So we recommend to use second line treatment which does not put the patient at additional toxicity. For instance, if the patient has a high load of viral infection, and T-cell depleting agent like ATG would not be the optimal approach. General frequently used second line treatments are extracorporeal photophoresis, TNF blocking agents, especially etanercept. You can also use ATG. That's the standard procedures. MMF is frequently given as a second line as well. Now, the results with all these drugs are unfortunately comparable. About 50% of patients become long-term responders, but it's still not satisfying, and we are urgently looking for improvement in treatment of graft versus host disease. We discuss a lot at the moment what is the reason that whatever you give does not improve the results, and it might be that we do not completely understand resistant graft versus host disease. Originally, people thought that we are not able to suppress the T-cell reaction and we need stronger agents suppressing T-cells. But more and more it's clear steroid resistance also means that the tissue is not able to regenerate. So what's more needed is regeneration of the tissue and immune regulation. And so the future, I think, of GvHD treatment will be not adding stronger immunosuppressants, but adding principles which improve immunoregulation. This can be done with cellular treatment. You can give regulatory T cells, or you can give perhaps mesenchymal stem cells. That can be done already now. But there are new upcoming drugs like ruxolitinib, which is an anti-inflammatory drug and could substitute for some of the corticosteroids. There are also new drugs which completely are not immunosuppressive but immunomodulating, like alpha-1 antitrypsin or cannabinoids, binding to cannabinoid receptors in the gut. But unfortunately, these are all drugs which are currently under clinical investigation, which are in clinical trials. So we strongly recommend if there's a trial for steroid-resistant GvHD or even for first-line treatment of GvHD, please include the patients in the trial, because this is the fastest way to advance and to have new and stronger results. The other strong recommendation is do not continue with the steroids at high dose, because steroids are not only beneficial, but they may also have a lot of side effects, well-known side effects, but also newly recognized side effects. So you always, if you decide the patient is steroid resistant, you should taper when adding a new drug. The future might be to detect GvHD earlier, severe GvHD earlier. A lot of centers are working on biomarkers of GvHD, which are prognostic at the time of occurrence of GvHD, of the first symptoms. And there is an international consortium working on that, and we are part of this consortium. So we're doing these biomarkers at onset of GvHD, and just in this year we start clinical trials. If patients have a very high level of biomarkers, then they get from the beginning intensified treatment. So the idea is the earlier you stop GvHD, the better is the outcome. And I think that is one direction for the future, and also one hope for the future. There are even some markers which allow us detection of GvHD before the patient is really sick, and that could be then the next step to do some kind of preemptive treatment, as we have learned from CMV, and this should really improve the results in the future.